So thank you everybody who is able to come to today's presentation. This is a CoLab Presents project in which we have researchers and organizers and people with lived experience from Canada, mostly from BC, coming to speak with other folks who are interested in harm reduction and drug policy about the work that they're working on. And today we have a really great presentation from folks from the BCCDC and the PEEP team. We have Charlene, Paul, and Jane. My colleague Corey has a slightly longer intro for those folks, but I'm going to pass it on to Corey now.
Hi, everyone. Thanks for being here. I'm really pleased to introduce these three wonderful individuals. Paul Choisel started formally working in harm reduction 15 years ago, doing outreach with Vancouver Coastal Health Authority. Through VCH, Paul was able to complete several capacity building courses, including facilitation, conflict resolution, trans inclusion 101, wellness recovery action plan, and take-home naloxone training, which allowed him to move into several different roles, including as a peer mentor and peer advisor. While maintaining his work with VCH, Paul has been able to be part of the PEEP Provincial Advisory Committee in partnership with the BC Centre for Disease Control. Paul is a member of the People with Lived and Living Experience Council at Health Canada. We also have Charlene Burmeister here. Charlene uses she, her pronouns and has over 13 years of experience in leadership roles of multiple advocacy groups. As well, she is the acting PWLLE Stakeholder Engagement Lead for the BCCDC, the lead of the PEEP Advisory Committee, Executive Director of the Coalition of Substance Users of the North, and as a board member of the Canadian Association of People Who Use Drugs. Charlene has years of experience in representing the interests of people with lived and living experience in the policymaking arena, bringing an understanding of how systems affecting the lives of people with lived and living experience work, as well as an understanding of how to engage with those systems in a constructive and goal-minded manner to achieve effective change for people who use drugs. Charlene has a deep knowledge of community of people who use drugs throughout British Columbia, along with a connection to people with lived and living experience in leadership roles across all health regions. His familiarity extends to service providers, stakeholders, and decision makers within government and other agencies that are connected to the community of people with lived and living experience. Charlene resides with gratitude on the unceded territory of the Lataco Dene Nation, which is colonially known as Quesnel. And last but not least, Jane Buxton. Jane is a professor emeritus in UBC's School of Population and Public Health and past medical lead for harm reduction at the BC Centre for Disease Control. She introduced the BC Take-Home Naloxone program in 2012 and championed peer engagement in all aspects of program development, implementation, research, and evaluation of harm reduction and drug policy. Over to you.
Thanks very much for the introductions, Corey. And welcome, everyone. And as Corey says, I was privileged also to be the principal investigator on this project that we're going to talk about today. And I'm delighted to co-present with my esteemed colleagues, Charlene and Paul. Just for those that may be unaware, that PEEP stands for Professionals for Ethical Engagement of Peers. And as Corey explained, they have very many other roles as well. Paul having been a take-home naloxone trainer for BCH for many years. And both Charlene and Paul participated in various committees as part of this guidance development. We developed the guidance for community take-home naloxone distribution and use. And Charlene also co-led focus groups with people with lived and living experience to get feedback along the draft guidance that we developed. Just briefly, some acknowledgements. This work was done right across Canada, what we now call Canada, which has been cared for and nurtured for all time by many First Nations. The presenters today are on the traditional, ancestral and unceded territories of many BC First Nations. And we acknowledge that Indigenous people live on these lands that originate from their own respective territories and the charter communities of Métis Nation BC and Inuit. And we are grateful to live, work and learn on this land. And really, I think it's so important to recognize the trauma and grief that people who use substances and their loved ones suffer every day due to the unregulated toxic drug emergency and the thousands of preventable deaths which have and continue to occur. So who was involved in this work? There were 3 co-principal investigators, myself in BC, Kay Rittenbach in Alberta, and Pam Lees in Ontario. As the nominated principal investigator, I was able to oversee the project and had 2 fabulous research epidemiologists, initially Amina and then Max. And we were based at the BC Centre for Disease Control, which is on the traditional, ancestral and unceded territories of the Musqueam, Squamish and Tsleil-Waututh nations. The project was a huge collaborative effort by many, many people who provided their time and expertise, despite also coping with personal and work pressures due to the overdose emergency. And then, of course, this was all going on when COVID-19 was emerging as well. So, you know, there was a lot happening, but people felt this was important and gave their time and effort, which was fabulous. So this is just an overview of what we're going to talk about today, and you're not going to hear from me throughout. Charlene and Paul are going to be talking about giving their insights in being involved in this guidance development and the feedback from focus groups. But I'm going to start with a brief history of take-home naloxone programs in BC and Canada, and then go through the process that we had, which was a very systematic and organized process of going through and developing guidance. So here we'll talk about, you know, the brief history of take-home naloxone. And the first program in Canada started back in 2015 in Edmonton. So it was a small regional program. There had been programs at that time running in the US, but not at a provincial level. And I had colleagues in the US who said, you know, you've got a supervised injection site. Why haven't you got take-home naloxone? And also from folks, including people from Vandu, saying we need take-home naloxone. People are dying and we can prevent it. So I was able to start the program back in 2012, and I am so grateful that we were able to initiate the program before the public health emergency happened. So we were organized, we had the program up and running for really 4 years before the public health emergency. Initially, when the program started, naloxone had to be prescribed. There had to be a prescriber, and therefore it was only available to people at risk of an overdose. In 2016, various things happened. We were seeing increase in overdoses. We increased the number of doses in kits to 3. We also, federally, there was, it was taken away from the prescription-only drug list, which meant at the end of the year, we were able to distribute naloxone without a prescription and to people who were at risk of witnessing an overdose. So there was a great response both federally and locally when things started to happen in 2016. So now I'm going to pass it over to Charlene and Paul, and I believe Charlene is going to take this slide.
Yes, thank you, Jane. Just in advance, want to let people know that it's -35 here, and I'm hoping I don't have any connectivity issues, but I would like to welcome everyone to the presentation. And I just want to talk a little bit about, you know, the recognition of the 1 million kits that were shipped across British Columbia since the program had started in 2012, and the 5 years since the public health emergency was declared, and that the preventable deaths continued at an unacceptable rate. People with lived and living experience created what we called naloxone is not enough, the letters from the heart of the crisis, which shared letters and perspectives from people with lived and living experience at the heart of the crisis. And as you see here, there are a few quotes. One, to the thousands of families who have lost their parents, children, siblings, aunts, uncles, and friends because of poison drug supply. I'm sorry that naloxone wasn't enough to save your loved ones. one of the other quotes we see is, after so many years, after so much death, after all the burnout, we're still relying on naloxone as our main intervention to address the toxic drug supply. I'm also going to just turn it over to Paul, and also just want to briefly acknowledge that I am calling from the unceded traditional and ancestral territory of the Lataco Dene Nation. And Paul, I'm going to turn it over to you for the next slide.
Great. Thank you so much, Charlene. My name is Paul Schwazil. I would like to respectfully acknowledge that I work, rest, learn, heal, and play on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Now, I'll provide some of the context about the BC Take Home Naloxone program. The program updates are posted quarterly on the Towards the Heart website, including the infographic shown here. As this infographic shows, over 2 million kits have been shipped to more than 2,200 sites across BC, including all provincial prisons, emergency departments, and most community pharmacies. Research with the BC Take Home Naloxone program found more than 90% of the kits that are reported were used by people at risk of an overdose themselves. That is, people who use drugs. Now for slide 8, the number of kits used is vastly underreported as distribution sites are too busy to collect and report the data. Instead of burdening the sites with the continual tracking and reporting, they'll be reporting for just a 2-week period, a couple of times a year. So this figure shows that since 2018, more than 70% of participants in the annual harm reduction client survey, people who are using harm reduction distribution sites, report owning a kit. So Bayesian modeling of take-home naloxone data from the 2015 to 2023 found 43% of the kits shipped were used to reverse overdoses. Now I'll pass it over to Jane.
Thanks, Paul. So you can see that the take-home naloxone kits have been running out the door. The BCCDC folks who oversee it, the program, have been really busy just keeping up with the demand. So now we're going to talk about the best practice guideline development. So the project was actually funded by CIHR, Canadian Institutes of Health Research, through the Canadian Research Initiative in Substance Misuse, known as CRISM. As I mentioned, the 3 lead investigators were from BC, Alberta, and Ontario, and originally we had somebody from Quebec, but unfortunately they were unable to continue due to increasing demands with COVID and other things. And the aim was to create evidence-based best practice document for take-home naloxone distribution in Canada. And I had the privilege of being the nominated PI along with my research epidemiologists. And I really have to give a shout out to the support we had at BC Centre for Disease Control, but also some fabulous students. These included medical students and MPH students who came and did their practicum, and without whom we wouldn't have been able to do this work. So this was the process that we had. We started with an environmental scan of take-home naloxone programs across Canada. We then did what's called a scoping review to look at the current published evidence. We engaged experts, and that included people with lived and living experience, so that we could prioritize and identify what the gaps were, what was missing. And then we looked at the evidence around these questions to develop and publish the guidance. So it was a very systematic, linear process that we went through. And usually, I mean, I like to just say, this is briefly what we found, and then we'll go through the process and the findings in more depth. But what we did find was there wasn't a lot of evidence being published about take-home naloxone, and the quality of the evidence was low. The project that we had was a huge collaboration of diverse expertise from public health professionals, clinicians, and importantly, people with lived and living experience. And the insights from the affected community was so important due to the lack of published evidence. And these are folks that have responded to thousands and thousands of overdoses. So it was really, really important. So now I'm going to hand over to Charlene.
Thank you again, Jane. So first we started the project to have a better understanding of the take-home naloxone practices and programs across Canada. So we first started with an environmental scan. We searched websites and resources and grey literature and spoke to between 1 and 3 key informants in every province and territory in English and both in French. Findings were synthesized and sent back to stakeholders for input and validation. Next slide, please. There we go. Thank you, Jane. Here's the report available on CRISM website. This site and link information is there for people. And so next slide. Next slide, please, Jane. This map shows that in June 2019, all provinces and territories provided free publicly funded take-home naloxone. All regions offered injectable naloxone. 3 regions, Northwest Territories, Ontario, and Quebec, also had nasal naloxone. Programs started at different times, have different kits, contents, and training naloxone scheduling also varied. There was differences between highlighted need for consistent policy and protocols across Canada. And those were some of the findings that we first drew out. I'm going to turn it back to Jane for the next section.
Thanks. So as you can see, we really had a variety of policies and programs across the country. So our next piece was to really, look at what did we really know? And this was to ensure that policies and protocols were evidence-based, looking at the current evidence and identifying what the gaps were in the knowledge. So we did what's called a scoping review. And this scoping review was a systematic review of guidelines, and was a review of systematic reviews and guidelines. And we call this an umbrella review. So we weren't looking at the individual papers on different small studies that were done, but looking at where it had been synthesized into guidelines and into systematic reviews. And as I said, this is called an umbrella review. And we searched the academic and the grey literature, and using keywords to actually see what there was out there in the literature. We initially identified 4,177 records, and after removing duplicates, we screened 2,855. And when I say we, I'm meaning our research assistants, our students, and our research epidemiologists, who did an incredible amount of work to go through them all. We excluded records for various reasons, and we did what's called citation chaining, which is looking at the things that we were including, the reports and the evidence that we were including, and just seeing if there were any references that we may have missed. And we found 2 additional ones. We had 47 left to look at in full detail. And you can see the list on the left-hand side of this slide shows the different sorts of articles and also the common themes that emerged from those articles, including the effectiveness of naloxone, safety, feasibility, acceptability of distribution, dosing and routes of administration, and it also included cost effectiveness and knowledge gaps as well. We published these findings in the BMC, Public Health, and there's a link throughout the slides, there are links to, so you can actually access these yourselves if you are interested. And if any questions emerge as we go along, please put them in the chat so that we don't lose those thoughts, or write them down so you don't lose them. So now I'm going to hand it back to Paul.
Thank you, Jane. The next question was, what do we do now? So in other words, what's missing from the current evidence, and what do people think are the most important questions to answer? We use what's called the Delphi process. Instead of getting people in a room where the senior or the most vocal individual can dominate and influence the discussion, we used an anonymous online consulting process to come to a consensus. The guideline development group generated a series of questions. 35 questions were brought to a 50-member panel, including people with lived and living experience, academics, clinicians, public health professionals, who voted and gave their rationale for their votes. Through this process, 17 questions were identified as most important. These 17 questions and the rationale provided were sent back to the panel, who voted again. 9 questions ranked highly, and 3 of these were identified for systemic reviews. Now, for those interested, here is the publication in the Harm Reduction Journal. Passing it over to Jane now.
So I just want to give you a little bit more detail about what the 3 questions were that we identified. The first one was the effect of route of administration, i.e. looking at injectable versus intranasal. The second was looking at the evidence to support the kit contents, and this one was fairly straightforward. And the third one was overdose response, and this was mainly looking at breaths versus compressions, or a combination. And I think, as many people know, this has been quite a contentious issue in different jurisdictions. And even in BC, where the training and our advice is to give breaths, there have been challenges with instructions from emergency health services, the call centres, and also we've heard quite loud vocal dissent from other jurisdictions. So before sharing the findings, what I'm going to do is to go into a little bit more of the methods of these systematic reviews. And for those that are aware, usually what we do when we're going through a systematic review is to develop the PICO questions, and this is looking at the population and problem, the intervention or exposure, the comparisons, and the outcome, and then the sort of settings that this is happening in. And as I've mentioned before, and will continue to mention throughout, thank goodness for our amazing MPH and medical students who helped to perform the reviews of all the literature that we were finding. We extracted data from the papers, and we used what's called the GRADE framework, and that stands for Grading of Recommendations, Assessment, Development, and Evaluation. And the framework actually considers the desirable and undesirable consequences, or the outcomes, the quality of the evidence, the values and preferences of those affected. So that will be people who potentially are administering the naloxone, but also those that have the naloxone administered to them, and resource issues. And this can be financial resources as well as other resources. And the strength of recommendations are determined to be either strong or conditional, and the quality of evidence is determined to be high, moderate, or low. And as I said, the quality of the evidence that we found was low throughout. So that's a little bit more about the actual process and looking at the literature. So I'm now going to hand it over to Charlene to talk about how we wanted to make sure we had authentic engagement of people with lived and living experience.
Yeah, thank you, Jane. I think we recognized it was imperative to get authentic input from people with lived and living experiences. They are the people most likely to administer and receive take-home naloxone. One of our students, Ali Adams, explored how to meaningfully involve people who access services in a guideline development. She performed a literature review and found 6 guideline standards and 18 publications. Next slide, please, Jane. This is the publication with PEEP co-authors who validated the findings. And we're going to go to the next slide as well, please, Jane. These are the 5 essential considerations for the guideline development and harm reduction. One is to establish a shared understanding for reasons for involving people with lived and living experience, and to respect their expertise. Also partner with people with lived and living experience to ensure appropriate engagement, and to incorporate perspectives of populations, my apologies, disproportionately affected by substance use, and also to secure resources. I'm going to turn it back over to Paul for the next slide.
Thank you, Charlene. So the next step was developing the guidance. Various working groups were developed. For the next slide. This slide shows the structure of various committees involved. The leadership group had 3 members, 1 from BC, Alberta, and Ontario. The research team and working group met regularly to ensure the project was on track. Charlene and I were members of the Guidelines Steering Committee, and I was also a member of the Affected Community Committee, an amazing group of people with lived and living experience, and Charlene attended the Clinical Expert Committee meetings. So I guess this is both of us. I'll go first. So basically, I have extensive experience in giving the monthly take-home naloxone training, and I'm also the peer mentor for the episodic overdose prevention site that we have with Vancouver Coastal Health at Robert and Lily Lee. So this was great opportunity to be part of this, to give my opinion and to be taken seriously as a professional. Sometimes as people with lived and living experience, that can be a problem. Charlene?
Yeah, just a little bit of insight. I was pulled into the project rather early, which is always a recommendation from, the inception of projects that include anything around people who use substances to be part of those processes. So I was really grateful to work alongside Jane and Max as well. And we worked together collaboratively to figure out our best approaches to engage people with lived and living experience throughout the nation, to make sure that we are including the voices of people with lived and living experience that were working in service provision roles, and other pieces also engaged service providers themselves. And it was just a wonderful experience for me, actually, to work alongside so many people with lived and living experience, some of which I knew, many of which I didn't. I learned a lot myself as well. The process of the face-to-face interviews and engagement with people with lived and living experience was a process that I greatly appreciated being part of, and also informing what that process should look like. And I think we're going to throw it back over to Jane for slide 32 now.
Thank you. So, as I mentioned before, we were dealing with low quality evidence. And when we looked at the literature, we found that, the evidence was that expert evidence can be effective to develop robust and trustworthy guidelines in the absence of published evidence. And in other situations, often that expert evidence is clinicians, people who are working in the medical field, or in the sort of population public health field. But for us, our main experts were the thousands, the folks with lived experience who had responded to thousands of overdoses over the many years that the program had been in existence. So we really gave priority to the input from and the insights from the affected community. Various committees were meeting through Zoom, and we reached informal consensus on the recommendations. And because the evidence was low, we called it guidance rather than guidelines, because there wasn't that set evidence that had been in studies and randomized controls trials and things, which of course it's very hard to do with naloxone. So these are the findings that we found. As far as the route of administration, which was our first question, there wasn't much in the literature with regards to administration by community overdose responders. Obviously, naloxone is used by paramedics, it's used in hospitals, but as far as in the community, there wasn't a lot there. And the values and preferences by family use who may prefer intranasal for ease of use, but many of the folks with lived experience really prefer to use injectable because it was easier to titrate. So because the evidence wasn't strong, we had a conditional recommendation, and that recommendation was that people should be offered either a kit with intramuscular or a kit with intranasal, so they could choose their preferred formulation, which may depend on the situation in which they may be using, but it would also be on their comfort using injectable versus intranasal. The second question was around kit contents, and this was pretty straightforward. We found that there should be a recognizable carrying case, gloves, rescue breathing mask, instructions, and that the naloxone, whichever type was being used, along with the tools to administer it. And then on the third topic, which was the overdose response, and just to kind of go back to the basics, which I think everybody here knows, was that when a person is having an opioid overdose, their breathing slows. So the oxygen in their blood, because they're not getting enough, they're not breathing as fast as they would normally be, there's not enough oxygen in the blood to reach their brain, but their heart is still beating. So it is important to give breaths so that the blood has oxygen in it and can be circulated. And this is very different from when a sudden cardiac arrest occurs, when the heart suddenly stops. Because somebody's been breathing normally, so there's oxygen in the blood. So compressions will ensure that oxygenated blood gets to the brain. So what we came out with was that the strength of the recommendation was strong, and that was due to a lot of input that we had from various folks, but the quality in the literature was very low. And now I'm going to hand it back to Charlene.
Thank you, Jane. So we did seek external feedback and received a lot from experts, including external the process, online surveys, focus groups, and with people who use substances with experience of responding to overdoses. We're going to go to the next slide, please, Jane. There were responses from 8 national and international experts. We had 73 people respond to an online survey. 75 people participated in the number of focus groups, which I co-led. Just a bit of a description of what that process looked like, working alongside with Mac. We just, brainstormed, what was the best way to engage people with lived and living experience, thinking about people that were working within service provision areas as well. We talked many people with lived and living experience across the nation. I just leaned into a lot of the people that I have with connections. I know that are working in settings that made a lot of sense to be hearing from them. We also allowed those people to reach out to other potential participants and gathered people and voices that way. We learned a lot in the focus group. With some information that we learned that practices that were being done that maybe were not the best approach, but we did also learn a lot around the importance of how people really were able to come up with innovative ways in the face of barriers around naloxone distribution and administration. Some examples are people living in really cold regions learn to keep the injectable naloxone close to their body to keep it warm so it wasn't as jellified. We heard things like a lot of contributions around what the kit should look like and how that response looks for them within their community. We talked a lot about people that were missing digits or fingers and people that had mobility issues and how that administration of the naloxone impacted them and innovative ways in which we could support people to be better prepared or better able to administer naloxone in the face of an emergency. It was almost unanimous for the support of rescue breathing when observing an overdose and concerns regarding painful rib fractures from compressions and a lot of those pieces. It was actually a really amazing process for me. I got to learn a few things that I hadn't really known before. And I think that there was a bit of an open dialogue as well, where we were able to have some knowledge translation and share with each other our experiences and our expertise in those focus group dialogues. So I appreciated that process, and it was really helpful to know that the leadership within this project were actually really supportive and open to the realities of the inclusion of people with lived and living experience as the experts in their own worlds and the work that they do. I'm now going to turn it back over to Paul, though, to speak a little bit further.
Thank you, Charlene. The guidance was published in the Canadian Medical Association Journal as open access, and more detailed report is available on the CRISM website. Now, here is the CMAJ publication, which was also published in French. And this is the report on the CRISM website. Now, this is a recap of the steps in the project. So we performed an environmental scan of programs across Canada, a scoping review of the published evidence to identify evidence gaps. We selected priority topics for systemic review, and we developed evidence-informed best practice guidance in collaboration with many experts, including people with lived and living experience. And we obtained external feedback and published the guidance. So we found the quality of the published evidence is low, and the project was a vast collaboration and commitment by diverse experts. So insights from the affected communities who have responded to thousands of overdoses was invaluable. Recommendations included offering a choice of kits containing either intramuscular or intranasal naloxone formulations. And this was a conditional recommendation, as there are maybe cost restraints. Provide rescue breaths if breathing is depressed, and if in cardiac arrest, give both compressions and breaths. Back to you, Charlene.
Want to include a list of references and links for those who wish to read a little bit more in detail. And finally, I think we just want to thank everyone for their interest and attention on this really important topic. We felt that for everyday superheroes who are save thousands of lives by responding to overdose and administering naloxone, I am going to head back over to Corey and Brittany, though. Thank you again.